Tharwat has worked in 3 different healthcare systems, Egypt, Saudi Arabia, and Ireland. He obtained his master degree from Tanta University 2006 and completed his MD degree in 2015. He successfully passed the European Diploma in Intensive Care in 2012 and completed the European Diploma Anesthesia and Intensive Care in 2018. He's currently working in one of the hospitals in Ireland, RCSI, Lewis Hospital Group. Dr. Tharwat is going to speak to us and in the next 30 minutes, including question about early goal-directed therapy and the trial. Please go ahead, Dr. Tharwat. Thank you.
Thank you, Muhammad, for the introduction, and I'm really delighted tonight to be between my professors and seniors, Professor Dr. Adil, Dr. Hisham, and Dr. Afifi. This is my KMC family. And of course, I would like to thank Dr. Saad and the organizing committee, Dr. Ansari, for having me tonight among those eminent speakers. And I think my talk today will be a base of the cake, and I promise I will not exceed the time limit. It's going to be a short lecture about the EGDT, or the early goal-directed therapy, and the trio. Trio are the 3 trials, the 3 famous trials who are recommending the traditional therapy against the early goal-directed therapy. And of course, you know, those guys, those are the European Society of Intensive Care Medicine and American Society of Critical Care Medicine. They gathered together and they turned the world upside down earlier in 2015 because they represented the radical departure from the prior sepsis definition, sepsis 1, sepsis 2, and of course, we are now in sepsis 3. I will not go through this because already highlighted by Dr. Hisham in the first lecture about the sepsis definition and septic shock definition and associated mortality. So what is the history of EGDT, or the early goal-directed therapy? Because before 2001, where the time of application of the early goal-directed therapy, there was no standard of care for early management of septic patients, either severe sepsis or septic shock in the emergency department. And the mortality was that much quite high, 40 to 50%. In response to that, the EGDT collaborative group challenged the paradigm of sepsis care as an ICU emergency by applying a protocolized approach for the management of septic patients as early as possible, the same like or extrapolation from the management of MI, stroke patients and trauma patients on the presentation to the emergency department. And you guys know this man. This is a very famous doctor. This is River Doctor. Dr. Rivers is an emergency and critical care physician in the US. And he is the owner of the most famous trial in sepsis, and what we were following for almost 10 years before, based on the recommendations of the surviving sepsis campaign. His famous trial, Early Goal-Directed Therapy in the Treatment of Severe Sepsis and Septic Shock, that is published in 2001. And it is a small, unblinded, single-center trial. He recruited 288 patients in the trial. And the main finding was the mortality reduction. There was a significant reduction in the mortality for the patients who are treated according to his protocol, which is the EGDT protocol. The reduction of mortality from 49% to 33%. And based on these findings, the recommendation of the major critical care societies worldwide came out by recommending early goal-directed therapy based on Rivers protocol. And it was the basis for 6-hour resuscitation bundle of surviving sepsis campaign guidelines in 2004, 8, and 12. After that, there is a lot of concerns regarding the scientific basis of the study and the conduct of analysis. And this is the famous EGDT protocol as you can see, starting by giving oxygen to the hypoxic patients, plus minus intubation ventilation. And of course, you have to insert a central line, arterial line, and if your patient is intubated, sedate and paralyze the patient, or both according to the situation of the patient. Your target CVB is 8 to 12 millimeter of mercury by giving crystalloids or colloids to achieve a target mean blood pressure of 65 plus. If not, you are gonna use vasoactive medications, norepinephrine or whatever, to achieve the target MAB. If you achieve the target MAB, measure the mixed venous oxygen saturation, central venous oxygen saturation, I mean. If it's below 70, so transfuse your patient to a hematocrit of 30 plus. If it is above 30, so you achieve the goals. So that was the stepwise protocol of Rivers. And the protocol, of course, was recommended by the Surviving Sepsis Campaign, but you can see it is impossible to tease out which intervention in this protocol made the most significant impact on the mortality. Is it the fluid boluses? Is it the MAP? Is it the transfusion? Is it the inotropic support that you can use if the patient has mixed venous below 70, or what? Or a combination of all together? So the components of EGDT have been a matter of controversy, specifically after the TRIC trial, this is famous trial comparing the restrictive versus liberal transfusion strategy for the critically ill patients with the target hemoglobin. AM-SHOCKNET trial, that is the lactate clearance versus central venous oxygen saturation as a goal for early sepsis therapy as an endpoint for resuscitation. And of course, CVB has been known to be a poor surrogate for the blood volume in critically ill patients. Moreover, the study population limited to the emergency department presentations only. He didn't enroll any patients from the ward or the critically ill patients. So there was a lot of criticism to Rivers, and I think after this, all criticism, the river starts to get dry. And after that, the first trial of the Trio came out in early March 2014, and it is a randomized trial of protocolized based critical care based care for early septic patients, or the process trial. It is a US trial, and the clinical question was, in adult patients with septic shock, does early goal-directed therapy compared with standard therapy reduce mortality at 6 days or not? It was a big trial, randomized controlled trial, non-blinded design. They screened more than 12,000 patients, and they enrolled a big number of them, 1,351. And the intervention was three arms in this study. One arm is Rivers protocol, the early goal-directed therapy for the 6 hours bundle with a dedicated physician, nurse, and research assistant for the prompts of the trial, and another arm for a protocol-based standard therapy based on the published expert opinions for the first 6 hours with dedicated physician, nurse, and research assistant as well. And the third arm is the usual care, no extra staffing, care by bedside physician for 6 hours, research assistant only to collect the data, and provides no prompting at all. So that was the outcome. The primary outcome was the mortality, and there was no difference at all in the mortality at 60 days between the three groups: early goal-directed therapy, protocol-based standard therapy, or the usual care. And also in the secondary outcomes, there was no difference in mortality, as you can see here, at 60 days or even at 90 days. So they concluded that no significant advantage with respect to mortality or morbidity of protocol-based resuscitation over the bedside care. The second nail in the coffin of Rivers was the second of the Trio, which is ARISE. It is the Australian Resuscitation in Sepsis Evaluation, and it is also an RCT published also in New England Journal of Medicine in October 2014, the same year of process trial, and almost the same clinical question, and it's comparing between early goal-directed therapy and usual care. Does it improve the mortality or not at 90 days? It is also a multi-center RCT. They recruited a big number of patients, and the follow-up at 90 days was intention to treat analysis. And the intervention here also almost the same of the process, EGDT as per reverse trial or usual care. And the usual care, RT-line and CVC might be inserted, might not be inserted. So according to the clinical appropriateness, and mixed venous oxygen saturation was not measured during the first 6 hours of intervention. And the outcome, primary outcome, was the all-cause mortality at 90 days. And the secondary outcome was the duration of stay, ICU, ED, and hospital length of stay. And there was no difference in the length of stay between both groups. Invasive ventilation, vasopressor requirements, RRTs, there was no difference at all between the EGDT or the usual care. Tertiary outcome was the all-cause mortality at 28 days and at ICU discharge 60 days. As you can see in this graph, there is no difference in mortality at 30 days, 60 or 90 days. So the third of the trial is the PROMISE trial. The PROMISE trial is the UK trial and is published in 2015 in March, and the same clinical question. Does the early goal-directed therapy compared with the standard therapy reduce mortality at 90 days or not? It was a multi-center randomized trial also in 56 hospitals in UK over 3 years, and they enrolled more than 1,200 patients. Sorry. The intervention also here is a comparison between the early goal-directed therapy as per reverse protocol with continuous monitoring of the mixed venous oxygen saturation as an endpoint for resuscitation versus the usual care, which was the control group. Arterial line, central line may be inserted if considered clinically appropriate. Mixed venous oxygen saturation was not measured in the first 6 hours, and decisions about the location of care delivery, investigations, monitoring, and all treatments made based on the clinical situation but by the bedside physician. The primary outcome, as you can see here, was the mortality, and you can see that there is no difference at all in the mortality between both groups, the EGDT versus the usual care. And the secondary outcome as well, length of ICU stay, both way, and also the outcome was SOFA score at 6 hours, and both were lower in the usual care group. So as a bottom line for the 3 trials, PROMISE, ARISE, and the process have shown no benefit or harm with early goal-directed therapy over usual care, unlike reverse 1. So do we continue with EGDT or not? Or this is the end of the road? This is a nice editorial published in the New England Journal of Medicine. And after that, in 2015, there is a meta-analysis included the 3 trials and plus River plus another trial of June's to compare the early goal-directed therapy versus the traditional therapy. And in this meta-analysis, you can see here that the early goal-directed therapy is not superior to the usual care for ED patients with septic shock, but it is associated with increased utilization of ICU resources. Another meta-analysis in 2017 included the 3 trials, plus River, plus some trials. They also included that early goal-directed therapy didn't result in better outcome than usual care and was associated with higher hospitalization costs across a broad range of patients and the hospital characteristic. So there is some limitations to the process, ARISE and the PROMISE, and caveats, yes, because all the trials used some elements of the early of the reverse protocol, which is the fluid resuscitation. They given the patient prior to randomization 30 ml per kg of fluids. So there was some precautions in the interpretation of the trials. But what? Do you think, guys, that the rivers got lost and it's getting dry or not? Let's see. There is always something is working here in this trial, in this study published in the JAMA in 2014. They studied the annual mortality in patients with severe sepsis. You can see here between 2000 and 2012 that the mortality decreased from 35% to 19% over 10 years. That is almost 1% per year in Australia and New Zealand, and 1 to 1.9% per year in the US. Those are the owners of the trials, right? So surviving sepsis campaign started to respond to the trials in sequence in 2014 after the process trial has been published. They stated that all groups in the study received an average of 2 liters of fluids prior to randomization, and 75% of patients in the process received before randomization antibiotics based on what? Based on the 3-hour surviving sepsis campaign bundles. And also the low mortality rate in the control arm of the process, which is the usual care, and the pending results of the ARISE and the PROMISE. Based on that, the surviving sepsis campaign didn't change their protocol of management, and they prefer to wait for the other trials. Moreover, they commented on the process that they didn't address repeating lactate as an endpoint for resuscitation, while literature supports that. So after the process and ARISE trial, again, they commented on the ARISE trial that they haven't demonstrated any adverse outcome in the groups that utilize CVB and central venous oxygen saturation as endpoints for resuscitation. Therefore, the surviving sepsis campaign said that there is no harm in existence and in keeping their bundle as it is without any adjustment, and they waited for the 3rd trial. So in 2015, they started to change their mind after the results of the PROMISE trial, and they mentioned that as long as patients have received timely antibiotics and fluid resuscitation, the campaign said requiring a measurement of CVB and mixed venous oxygen saturation in all patients is not supported by the available evidence. As the results of PROMISE are in line with the results of PROCESS and ARISE studies, the hemodynamic bundle will be revised soon. This re-evaluation by the surviving sepsis campaign currently underway. And finally, they give us the 1st-hour bundle, which is discussed already in the previous lectures. So you take a home message, guys, from this few minutes that sepsis is a dynamic syndrome with a lot of variables, either laboratory or clinical variables. And the most important to put in your mind that early recognition, early source control, early antimicrobial therapy, and fluid resuscitation, early escalation of antibiotics remains a fundamental treatment goals. And thank you.
Thanks very much, Dr. Tharwat Aisa, for that very informative lecture. It's not only to remind us about clinical and basic facts on dealing with the patient, but also remind us that we should stick to research. We should follow the evidence-based medicine, and we should do as much research and read as much research as we could, just to support our practice, because there is no room at the moment in our current practice to just because I've done it, it works. No, we have to go back to the evidence and follow it. So so looking at the questions, Dr. Tharwat, what is the new guidelines for normal saline bolus in children, or for any panelists?
Sorry, Mohammed, normal saline bolus, it's recommended 30 ml per kg.
And children.
And some national guidelines advise to give 500 boluses every 15 minutes and reassess your patient. So one size not fits all in this scenario. You have to reassess your patient every bolus you are giving and reassess your patient clinically and by biomarkers as well, mixed venous oxygen saturation, lactate. If you are using the echo filling pressures and you are using your ultrasound, so go thoroughly through the parameters, either static or dynamic parameters, and to achieve the endpoints for resuscitation.